We are pleased to provide the video recordings of Florida Digestive Diseases update held on December 4th and 5th, 2021 in Orlando, Florida. This is video recording from Session 2, Hot Topics in the Liver. The lectures are as follows. Abnormal Liver Tests, How to Work Up, by Dr. Paul Kuo. The second lecture was on Fatty Liver Disease, How to Apply the Brakes, by Dr. Kirti Shetty. The third lecture was on Liver Mass on Imaging, Is it HCC, by Dr. Hashem El-Serag. The fourth lecture was on Hepatitis B and C, What is New for 2022. This was concluded by case presentations and discussions by Dr. Arvind Murali. Please enjoy the session.
So without further ado, I'm going to introduce our first speaker. Paul will actually be doing two talks during this session. I'll only introduce him once. But Paul is near and dear to my heart. When I met him, he was at Indiana University, which is my alma mater, and he did fantastic work there. And then for people that do fantastic work, they move up the food chain. And he was recruited to Stanford, and he's the professor of medicine and head of their hepatology section at Stanford in Palo Alto. And Paul is, again, one of these people that is cut from this cloth of really measured, careful assessment, using a really sharp and bright intellect, and really approaches things from a very sort of academic and science-based standpoint. So we're really happy to have him. He's come all the way across the country to join us. And the first thing that we've asked him to talk about is abnormal liver tests and how to work that up. So Paul, welcome, my friend.
Thank you, and thank you so much for the very kind invitation. Oh, please. Thank you so much for the kind invitation to come out here. This is a beautiful place. I was telling Rob just before I came here, I had been here a few years ago and did not recognize about half the convention center. So again, let's go ahead and get started. We're going to talk for the first 15 minutes or so about how we evaluate abnormal liver tests, which has been something we've seen quite frequently now, particularly over the past 2 years. So just as a way of foundational statement, so we talk about liver tests or liver chemistries, and they have historically been called liver function tests, but this is actually a misnomer. We typically see elevated aminotransferase levels or alkaline phosphatase levels, and these are markers of liver injury, not indices or degree of liver function. We do have liver tests that do reflect liver function. These are the albumin, bilirubin, prothrombin time. And just remember that these sometimes are affected by extrahepatic factors. So for instance, prothrombin time will go up if you have received antibiotics. If you have hemolysis, the bilirubin can be up. Severe systemic illnesses such as the SARS-CoV-2 infection can reduce your albumin levels. So they're best known as liver tests or liver chemistries. AST and ALT are the most widely ordered liver chemistries that reflect injury to the liver. ALT is in the liver, and we have in the ACG guidance that we published a few years ago, based on liver-related mortality, we recommended that 29 to 33 international units be considered the normal level. And you will see many institutions, including my own, they fluctuate. They come quite a bit higher than that, but that likely reflects contributions of steatosis. AST is more widely distributed in the liver, but also in cardiac, skeletal, kidney, brain tissue, and therefore it can be a little bit more sensitive to extrahepatic causes. So I'll give you a perfect example. If you have somebody, we see consults for, say, higher AST levels, and for instance, we found people who do spinning, their AST levels can go to very high levels, and then you check the CK, it's actually in the several thousand range. And so you just have to be careful with AST level for that reason, and these levels go up when liver cells die by necrosis or apoptosis, as shown down here. The AST-ALT ratio is very helpful. If it's greater than 2, this really suggests alcohol use disorder, and this has been described, and it's due to pyridoxine deficiency. That is, those who have alcohol use disorder are pyridoxine deficient. This suppresses ALT levels to a greater degree than AST. Alcohol is also a mitochondrial toxin, and so particularly with the SARS-CoV-2 pandemic, we've seen much more of this. AST levels are also higher in those with cirrhosis. And so cirrhosis of any etiology, be it fatty liver, viral hepatitis, the AST levels are typically higher. And then finally, of course, celiac sprue, there are a variety of other causes as well. I bring this up because the last 2 years have brought about a dramatic increase in alcohol use disorder. This was just published in JAMA, and this just shows the rate of additions to the liver transplant waiting list amongst those with acute alcohol-associated hepatitis. During the discussion, maybe we can talk about the evolving alcohol exception pathway policies that we're all having to consider in all of our centers now. And so it's important to make sure that you have this as a diagnosis. Yes, this AST and ALT levels are evolving upward, and I hate to bring this up just before lunch, but this is a substantial problem. And we all need to get a handle on this. We'll talk a little bit later about fatty liver, and Dr. Shetty is going to solve all of our problems there for us, right? And but again, we just have to be cognizant that when you see someone with elevated AST and ALT, you should be thinking steatosis. So we also have cholestatic profiles, and cholestatic profile just means an impairment in bile flow, and typically defined by an elevation in alkaline phosphatase level, which you can confirm with a GGT or very rarely a 5' nucleotidase. There are some alk phos levels that will go up in those that are less than age 18 because of bone growth. Also pregnancy, and then blood groups B and O also can also be associated with a slightly increase in alkaline phosphatase levels. Remember this, the alkaline phosphatase, and we have all these world-famous biliary endoscopists here, the alkaline phosphatase comes from the canalicular membrane of the hepatocyte, not the bile duct cell. That's an important distinction. It's actually it's a liver enzyme, not a bile duct secreted. So that's a very important aspect of alkaline phosphatase. And again, any gallstone or anything like that can, if you will, is obstructing, will cause these bile acid flow, will actually cause the alkaline phosphatase increased synthesis from the canalicular membrane, which translocates to the basolateral membrane, and you measure it in the serum. So when you have somebody with elevated AST, ALT, alkaline phosphatase, what are our strategies? Well, you should be confirming and making sure that you indeed have a hepatitic, which is AST and ALT, or a cholestatic profile. So if the ALT is elevated, the AST should be elevated. If the alkaline phosphatase is elevated, the GGT should be elevated. And again, the important things are in the initial evaluation that you should be immediately asking about alcohol use of medicines, over-the-counter products, herbal supplements, and of course, look for metabolic syndrome factors, which Dr. Kirti Shetty is going to cover with us. The exam is actually more for stigmata of advanced liver disease rather than a specific disease etiology. That is, you're not going to see, for instance, a Kaiser-Fleischer ring routinely, but you will be able to see spider angiomata, palmar erythema, anything that suggests cirrhosis, and that's what you're mainly looking for when you examine somebody. I do want to talk about all of the supplements that are out there because as all of you do your medicine reconciliations, this is a big deal and this is a big problem. Patients, particularly I'm in California where they really like their supplements, and they will tell you, doctor, they're natural. We sit down with them and we say, not everything in nature is safe, right? And so we have been telling them, and we have transplant, and I bet if we were to poll the other people here, you transplant for complementary alternative medicine, acute liver failure, not infrequently. And so just you have to educate. There was only one country in the world that previously did safety studies for supplements. That was Germany, and they did it. They had these monograms, and they would actually, they didn't prove efficacy, but they would actually do safety studies on supplements. At least they would not be dangerous, but they're no longer doing that. So, hepatocellular injury, AST and ALT are elevated. Cholestatic injury, alkaline phosphatase is elevated. And in your syllabus and in the slides that I provide also, you'll see that there's an R level that you can use as well to help distinguish these if necessary. If the hyperbilirubinemia is there, you can call this just isolated hyperbilirubinemia, and we'll go over this momentarily. So stratify your approach based on the degree of AST and ALT elevation. So we have borderline elevations, particularly now that the AST, ALT upper limit of normal is low, you don't need to go rigorously evaluate every ALT that's 50, but you do need to assess these. When they become higher, you need to be a bit more proactive in your evaluation, and obviously with higher levels, you really need to evaluate quickly. If you have acute liver injury with INR that's going up and you have hepatic encephalopathy, you have to call the Orlando Transplant Center if you're around here, because these people need to be evaluated for acute liver failure. And this is regardless of the ALT level. Please remember this. So what about a borderline ALT level? So less than 2 times the upper limit of normal. Say someone presents the ALT is 50. So you evaluate these individuals, take your history and physical, you discontinue your hepatotoxic medicines, you tell them that alcohol consumption should stop. And sometimes the more resistance you get here, the more you know alcohol is contributing to the elevation in your AST and ALT, and metabolic syndrome counseling is required. The initial evaluation, viral serology, surface antigen, core antibody, surface antibody, hepatitis C, there should be now universal screening for this, and then an iron panel as well. And if you haven't done an abdominal ultrasound, this is a nice test to pick up steatosis of the liver. If it's normal, then observe and you can follow them. If it stays elevated, you can continue to evaluate these individuals. But again, it's less likely you're going to find autoimmune hepatitis. You may find some other diseases here, but again, typically these are individuals who have mild metabolic syndrome, but you do need to complete the evaluation should they remain elevated. The same thing is true if they're slightly more elevated. However, you may not defer the evaluation. An initial evaluation, again, is the same. Look for viral hepatitis, alcohol, metabolic syndrome, and discontinue any potential medicines or supplements. But then, depending on the degree of elevation, you may wish to move forward with your investigation sooner. And again, if you don't find a diagnosis here, you should move forward with a diagnostic liver biopsy. Again, more urgent with the higher ALT levels, and you need to be thinking when the ALT is 5 to 15 times the upper limit of normal, your immune markers, and you're now thinking maybe acute viral hepatitis as well. And again, here also, if you start seeing someone who has asterixis, you need to be thinking about acute liver failure. And these individuals, a liver biopsy would likely occur sooner. What about severe elevation? Again, you need to move more quickly on these individuals as well. And here you need to start thinking about also things like acetaminophen overdose in addition to other etiologies that we've discussed here. And again, if you have severe liver injury, and for instance, the ALT is very, very high, then you need to be thinking that you should consider N-acetylcysteine, sending to the hospital and considering N-acetylcysteine while you complete the evaluation. There we go. And then the differential, if you see a very high AST or ALT, is actually quite short here. You do need to do your evaluation, but for instance, viral hepatitis rarely is going to cause an ALT above 10,000. It's ischemia, it's acetaminophen, and then a very rare complication in the 3rd trimester of pregnancy, herpes simplex hepatitis, can get very, very high ALT levels. But again, these are individuals that need prompt evaluation. And again, just to point out, acetaminophen toxicity is the most common form of acute liver failure in the US and accounts for over half of all cases. Maybe 10 years ago, McNeil lowered the acetaminophen dose, safe dose from 4 grams to 3 grams, largely in response to all of this acetaminophen overdose that we were seeing. For alkaline phosphatase, again, confirm with a GGT. You image these individuals. If the GGT is normal, it's not. The alkaline phosphatase is bone or another cause. If the GGT is abnormal, image them with a right upper quadrant ultrasound and look at your immune markers, ANA, smooth muscle, and anti-mitochondrial antibody. If the ultrasound is normal, you can observe or you can consider a liver biopsy moving forward. And again, if there's ductal dilatation, MRCP is our first line that we use. ERCP we use if we find something that requires sampling. And then looking at the alkaline phosphatase with the transaminase and bilirubin that's also potentially elevated. Again, remember your hepatotoxic medicines. And again, but as you can see here, it's the same algorithm. You need to image these individuals, and then you need to potentially biopsy if the imaging is normal. These individuals can have either an immune-mediated hepatitis, drug-induced, if the imaging is unremarkable. What about total bilirubin? If it's unconjugated, the differential is actually relatively short. Hemolysis, Gilbert syndrome, or drug-induced. And these individuals, particularly if the AST and ALT are normal, it's typically Gilbert syndrome that we see. And again, we used to have all kinds of creative ways to prove it was Gilbert's. We'd give phenobarbital, you'd have them show up fasting. Now it's so easy. You just order the UGT analysis and you have your answer. So, and this is true for a lot of liver diseases nowadays. So, but if you have an isolated bilirubin level and it's unconjugated, the predominant diagnosis you're going to entertain is Gilbert syndrome. But a conjugated bilirubin that's isolated, in these individuals, they truly do have liver disease in the majority of cases, and it's typically medicine-induced. If the AST and ALT are absolutely normal, which you see, you should consider two rare causes, Rotor syndrome and Dubin-Johnson syndrome. And again, nowadays we have genetic testing for these. We used to do all kinds of complicated coproporphyrin measurements and other things. You just now send off the genetic analysis. It's actually quite straightforward. Otherwise, you're looking for typically drug-induced causes, and then TPN, biliary obstruction certainly happens and they need imaging. So in summary, you will often encounter elevated liver chemistries in practice. Truly healthy ALT and AST, 29 to 33 for males, 19 to 25 for females. The recent pandemic has led to an increase in NAFLD and alcohol-associated liver disease, which will be a substantial portion of the evaluations you're going to complete. The algorithms that you should follow are provided based on the degree of elevation. Prioritize your evaluation, as well as evaluate for elevations of alkaline phosphatase, bilirubin, and our mixed patterns. And I will stop here. And again, thanks so much for the kind invitation.
So our next speaker is Kirti Shetty. And for those of you who know V, it takes a lot to get praise out of V. You got to be really, really good. And Kirti is one of the very few people that if you mention somebody, V, who's really good, etc., Kirti is always the one that comes up. They have a history together at UAB. She's now professor of medicine at Maryland. She's head of the hepatology program. But V just goes on and on about her special qualities, her work ethic, her smarts, etc. So we're delighted to have her. She's a really good friend of V's and us as well, and it's delightful to have you. We've asked her to talk about fatty liver, how to apply the brakes. So welcome, Kirti.
Thank you, Dr. Haas, and thank you for this invitation. It's such an honor to be here at your inaugural conference, and of course, wish you every success with this endeavor. So what I'm going to do over the next 15 minutes is talk about fatty liver disease, specifically how we apply the brakes so that our patients don't careen off this cliff. These are my disclosures. And this is what I'm going to try and cover. I'm going to talk about the disease burden of fatty liver disease, how we predict mortality, and the various strategies that we have of applying the brakes in terms of lifestyle interventions, some medications, bariatric surgery, and the emerging field of bariatric endoscopy. Fatty liver disease, non-alcoholic fatty liver disease, which is what I'm going to restrict my talk to, as you know, is widely prevalent and is thought to affect approximately a quarter of the world's population. In this country, NAFLD is the most common cause of chronic liver disease as well as cirrhosis. And its prevalence varies according to race and ethnicity. Latinos are most affected by this disease. Over the next decade, NAFLD and NASH is expected to increase empirically, not just in terms of its incidence, but also in terms of the morbidity and the mortality that it will result in. Non-alcoholic fatty liver disease is an umbrella diagnosis. It encompasses non-alcoholic fatty liver, or the so-called bland steatosis that you see on liver biopsy, as well as its more sinister counterpart, non-alcoholic steatohepatitis, where a liver biopsy, in addition to steatosis, will show lobular inflammation and ballooned hepatocytes. Now, there's a wealth of data out there that has delineated the natural history of NAFLD, and we know that about 20% of those with fatty liver will go on to develop NASH. Of these, another 20% will develop cirrhosis. There is a small fraction of people, about 4%, who bypass NASH completely and transition from fatty liver to cirrhosis. And more recent data shows that this is actually a dynamic process, and even in the absence of any intervention, people can regress from NASH to NAFL. So what is it that predicts liver-related morbidity and mortality? It's fairly clear now that the presence of fibrosis, significant fibrosis, as defined as F3 and F4 fibrosis, is the determinant of which patients suffer the decompensations of liver disease and which patients die of their liver disease. And so the essential elements to prevent NASH progression are twofold. First, it is important to target steatohepatitis. Resolution of steatohepatitis is assessed by the NAFLD activity score, which is a linear histological scoring system, is important. And secondly, there should be an improvement or at least no worsening in the fibrosis. And these two are, in fact, the FDA-endorsed endpoints for clinical trials in NASH. Let's talk first about lifestyle modifications in NAFLD. This should be the first-line intervention in all of your patients with non-alcoholic fatty liver disease. Weight loss with diet and exercise is recommended. And this is because the effects of weight loss have been well documented. This very important study showed that you need at least a 5% weight loss. This is as measured against your total body weight at the onset, to decrease hepatic steatosis. More than 7% leads to NASH resolution. And in order to achieve fibrosis regression or stability, a greater than 10% weight loss is necessary. The diet recommendations in NASH on the surface seem very simple. Obviously, you need to take in less calories, 1,200 calories a day for women, 1,500 for men. And this has been shown to be associated with weight loss, with decreased insulin resistance, as well as decreased intrahepatic fat. And it appears to be important in normal weight NAFLD, which I don't think we'll have time to get to today. And the Mediterranean diet is the one that has been most studied in NAFLD. It's low in saturated fats, does not have any dietary fructose, and is high in whole grains. Exercise is a very important adjunct to diet and leads to added weight reduction. Aerobic exercise is key. About 75 to 150 minutes a week of vigorous intensity exercise, if possible. And hepatic fat has been shown to be reduced by exercise by all these mechanisms. Unfortunately, lifestyle modification, in addition to being very unpopular, is difficult to maintain. This study has shown that only 10% of individuals reach their target BMI at 1 year, and less than half of them are able to maintain their weight loss at 5 years. What about other lifestyle interventions? So, almost all of your patients, or at least mine in Baltimore, will ask about alcohol. And thanks to this very nice study that was published last year, we now have real data on which to base our recommendations. The study followed over 8,000 individuals for about 11 years and found that any alcohol at all doubled the risk of liver-related events. And so this recommendation from the recently published clinical practice guideline, the AGA, says that all adults with NAFLD should restrict alcohol and smokers should avoid it completely. You can't really give a liver talk anymore without talking about our favorite beverage. And coffee has indeed been shown to be beneficial in NASH. There are small biopsy studies which have shown a reduction in inflammation and fibrosis. And a meta-analysis of regular coffee consumption, defined as at least 2 cups a day, shows that there's a significantly reduced risk of NAFLD, and also in those who have NAFLD, there's a decreased risk of liver fibrosis. I show you this slide only to highlight the point that the pathogenesis of NAFLD is complex, multiple pathways, multiple hits. 4 main therapeutic approaches have been attempted. One is to target hepatic fat accumulation. And the examples of this are PPAR agonists as well as FXR ligands. Well, secondly, we attempt to reduce oxidative stress and inflammation, an example being apoptosis signaling kinase inhibitors. Thirdly, the intestinal microbiome has gained a lot of attention, and there's an interest in modulating that. And fourth, a decreasing of hepatic fibrosis. So obviously this is a crowded landscape and you're not going to be tested on this slide. There are many agents currently undergoing evaluation for NAFLD. Several have fallen by the wayside. And so currently there are no FDA-approved therapies. ASLD guidelines suggest that either pioglitazone, vitamin E may be used to treat biopsy-proven NASH. This is based on the pivotal PIVENS trial. There are a couple of caveats that you need to be aware of. There's increased all-cause mortality with vitamin E, and weight gain has been noted with pioglitazone. These are some of the more promising agents in terms of NASH therapeutics, and I'd just like to talk briefly about some of them. The first of these is saroglitazar, which is a PPAR, a dual agonist, and has been shown to have an antifibrotic and anti-inflammatory effect. It's a first-in-class therapy. It's already approved in India for type 2 diabetes and dyslipidemia. And these are 2 important studies. The evidence is 2, which is a phase 3 trial completed in India, which met primary and secondary endpoints. And the evidence is 4 trial, which was complete in this country, just published in Hepatology, also met its primary endpoint, and so a phase 3 trial is planned. The fascinoid X receptor has been the object of much interest in NASH because it seems to mediate many of these pathways. And obeticholic acid is a very potent FXR ligand, which has been studied in the Regenerate trial, the phase 3 trial, which demonstrated improvement in liver fibrosis without worsening of NASH. However, the FDA declined to approve this, citing some safety concerns and requiring long-term follow-up. Undeterred by this, Intercept, which is the makers of OCA, have a phase 3 trial currently in the works looking at cirrhosis, and another agent which is planned for clinical trials soon. Resmetirom is an interesting agent, first-in-class a thyroid hormone receptor beta agonist, and has shown some benefit in phase 2 trials. Phase 3 trials are ongoing. Ceneroc is a dual chemokine receptor agonist and has shown antifibrotic activity. Despite the failure of both the phase 2, when I say failure, it didn't meet the primary endpoint. Both phase 2 and phase 3 trials, there's a combination trial that's planned with an FXR agonist. Aramcol is an interesting agent because it reduces hepatic fat, encouraging results from a phase 2 trial, and has actually been granted fast-track designation status by the FDA for the treatment of NASH. There's an ongoing phase 3-4 trial. Just want to talk briefly about anti-diabetic agents for NASH. Pioglitazone is currently the only agent that's approved for both pathologies, and there are other agents that are also in trials. Semaglutide, this phase 2 trial was recently published in the New England Journal of Medicine, and it is planned for a phase 3 trial with cilofexor. There's a lot of interest in the role of the gut microbiome, dysbiosis, and NAFLD, but currently there's really no convincing data that probiotics are useful. Just want to talk briefly now, switch to bariatric surgery. Bariatric surgery, as you know, is restricted. A meta-analysis data has shown encouraging results, and this prospective series from France actually confirmed many of those. They found that NASH resolved in 84% of individuals, and fibrosis disappeared completely, including bridging fibrosis in over half of these patients. So this reduction seemed to be progressive. I just want to talk briefly about endoscopic bariatric and metabolic therapies, which is a very new form of treating obesity. There are various types: intragastric balloons, which have been most studied in NASH, and they result in rapid weight loss, have been demonstrated in a randomized clinical trial to decrease the NAFLD activity score. Endoscopic sleeve gastroplasty, the so-called overstitch technique, has also been shown to improve metabolic dysfunction, steatosis, and there are 2 ongoing randomized controlled trials. The post-procedure, there's really no data yet on NASH. There are various duodenal devices listed here, which have been shown in small series to be effective. So to summarize, NAFLD has tremendous clinical and economic burden to patient society, and as we know, this burden is growing. NASH is the progressive form of NAFLD, and the presence of fibrosis predicts liver-related mortality. The pathogenesis is complex, and therapeutics are based on pathogenetic pathways. Preventing NAFLD progression requires resolution of steatosis, regression of fibrosis, and lifestyle modifications really are the cornerstone of therapy, since weight loss has been shown to cause fibrosis regression. Currently, we have no FDA-approved therapies. You may consider vitamin E for non-diabetes-related NASH, also in some diabetics, pioglitazone, but be aware of safety concerns with this. Consider bariatric surgery for those who have severe obesity or comorbidities, and bariatric endoscopy if the financial situation permits. There are multiple clinical trials underway, and hopefully in a year we'll be presenting a completely different talk. Thank you.
Fantastic. Thank you very much. So it's my pleasure to introduce Hashem El-Serag. He's probably familiar to all of you. He's a professor of medicine at Baylor College of Medicine in Houston, Texas. He has the distinction, I think, of being the last person that I was with at a meeting before we had the shutdown from the COVID. I remember being with him in Baltimore at Hopkins, and shortly thereafter, things sort of shut down. So that's sort of a sad note, but maybe his presence now with me indicates that things are going to be much, much better.
Thank you very much. That's how I usually introduce myself. I'm the person who Rob Haas saw last before COVID. So thank you for inviting me here. I don't have a disclosure slide. Nobody cares about what I have to say. No, I'm just so it's a tough topic, which is basically liver masses. I'm sure you've heard it before. It's usually flying pictures of images that no one can remember. So I'll try to make it slightly memorable and slow down on important things that simple people usually look at practice. And I'm really a simple person. So you divide it into benign and malignant, and my key word will be here: relax or don't relax, okay? So the important thing, and my first really important thing, is the way you interpret the imaging and the testing has to be in the context of pre-test likelihood. So if you have someone with cirrhosis, you really cannot relax. it's liver cancer, intrahepatic cholangiocarcinoma, you have to be on your mind. Now, if someone has no liver disease, you can slightly relax because hepatocellular carcinoma is not likely. Actually, the way you interpret images is so important and so determined by the underlying presence of chronic liver disease or not. So that's my first tip here. So we'll give you few instances or examples of common hepatic masses, both malignant and benign. Let's start with do not relax here. Someone with cirrhosis, you're either doing surveillance or someone stumbles on a nodule or maybe a rising alpha-fetoprotein. If that nodule is small, by small meaning less than 1 centimeter, the reality is there's nothing you can do to definitively make a diagnosis of hepatocellular carcinoma. Neither biopsies nor imaging are good in that instance, and my friends in the transplant world says it's not really useful because they don't get MELD exception points when you have a Ditzel there. So what do? You follow it up. Unfortunately, it's a lot of work for you and the patients over time, ultrasound or cross-sectional imaging every 3 to 6 months. If you have a mass that is quote-unquote large, which is 1 centimeter or greater, you go for cross-sectional imaging, dynamic imaging, triple phase, with or without contrast, diagnostic imaging for HCC, either a CT or MRI. And then you categorize it, and this is my second tip here is, if you're into this business, your radiologists have to be able to report into this LIRAD system. It's a liver reporting and data system. So it's a new classification that is decent, at least on the extreme ends, and gives you a common language to communicate with. So just remember, there's a LIRADS, and it ranges from 1, which is benign, 5, which is malignant. I'll give you a few more words about it because I think it's worthwhile that. But before I do this, which becomes the genesis of the LIRADS, Typical Talks gives you a classic picture like this. It says a nodule and a cirrhotic. You give them contrast. There is arterial hyperenhancement. Most of those images I'll be reading left to right. Somehow I feel compelled to tell you I'll be reading left to right since Arabic is my first language, and I'm always thinking I'll be stuck in a crowd where everyone reads right to left. So I'll be doing you left to right, okay? So arterial hyperenhancement, a peripheral capsule, which you can see both on the left and right, and then in the delayed venous washout, the runoff of the contrast, and the rest of the liver is taken, okay? So arterial hyperenhancement, portal or delayed venous washout. So take those 3 classic things that I mentioned, add to them threshold growth, which means increasing over time, and that basically is your LIRADS. They take those 4 criteria, cross-tab them. If you have more of them, you become more red. If you have less of them, you have less of red. If you're really, really red, that's LIRADS 4 or 5. Your likelihood of having hepatocellular carcinoma is really, really high. Okay? So hepatocellular carcinoma, one last look before we leave the topic, now that I mentioned it. Arterial hyperenhancement, you look at the capsule, delayed venous washout. Look at the pictures one more time. We're done. Do not relax. Again, a cirrhotic, the biggest differential diagnosis for a malignant tumor in a cirrhotic, it's just something becoming more and more recognized, is intrahepatic cholangiocarcinoma. Typically, we think of it in the setting of PSC, but reality is it's only 20% of the time when PSC is present, and we find it now more and more in just garden variety cirrhotics. What are the distinctions? And admittedly, it's tough sometimes, and I'm collecting the best pictures, but it is. Capsular retraction because of the intranodular necrosis and scarring. It is a non-enhancing indistinct mass, and quote-unquote classic, but it only shows up on boards, adjacent biliary ductal dilation. So that's your second mass. Do not relax. You may resort to biopsies to make the distinction between the two. Is the distinction perfunctory? Not really, because the treatment can differ and the prognosis differs. All right, so take a deep breath. You can relax a little bit here. We're talking about very common and very benign lesions. So if you're just a practitioner, the odds are you're going to see something like this. Hemangiomas, they're very common. I mean, depending on the estimates, 10% of the population may have them. They could be large, they could be giant. Most of the time you don't have to do anything. Rarely they're symptomatic, and then you can treat them. You don't need to be very smart. Your radiologist doesn't have to be great. Most people make that diagnosis. So peripheral nodular enhancement, and look at the pictures left to right. This is just beautiful. Peripheral nodular enhancement, then it keeps creeping in centripetal from the periphery to the center, and then if you move to the right, you see it now full-fledged like that. Bingo, relax, nothing to do, hemangioma. So management, you don't really have to do much. If it's large and bothering you and bothering the patient, you could do one more follow-up just to confirm that it is what it is. You don't discontinue oral contraceptives. There is no problem with pregnancy. The symptoms could be related to pain, extrinsic compression, etc. In my experience, even if they have those symptoms, it's not related to that. So I don't jump on treatment, and these are the treatments that are mentioned. Last line always talks about the board question, Kasabak-Merritt syndrome. You'll never see it, so don't worry about that. But okay. So the next most common nodule is this. Now, many people don't think of this as a common condition, but it is. It's the next most common nodule you're likely to see. It's focal nodular hyperplasia. It's important to make the diagnosis because you can relax. You don't have to do anything. Typically, it's 3rd to 5th decade. Typically, it's women. It's well circumscribed. And here is the tip to understand imaging, because you'll forget everything I say right now. Remember, it's just normal hepatocytes that are put together in an abnormal way. So the way the uptake in the imaging, the way the biopsy shows, it just shows normal hepatocytes that are disordered, and there is this classic thing due to arteriolar injury, we think, that is called a central scar. The site is important because most of FNH is subcapsular, and as I mentioned, at least half would have a central scar. So just to emphasize the point, central scar, abnormal arterioles, normal cells. This normal cells and normal ducts will come handy later on where we're trying to differentiate it from adenomas, okay? So let's hope this moves. Yes, again, pathology showing the central scar. Let's go from left to right. Because it's normal cells, it's isotense or hypotense. You give it contrast, it takes up the stuff except for the central scar. And if you go to the extreme right, that's your T2 and an MRI, and it shows an isotense, again, iso because it's normal cells with a central scar. You make that diagnosis, you really don't have to do anything after that. No indication for discontinuation of oral contraceptives, follow-up during pregnancy, etc., etc. We don't know why it happens, so therefore we can't reverse it by reversing risk factors. Hepatic adenoma. Do not relax. I mean, adenoma, for most of us who scope, you think of it as a small polyp. Oh, no big deal. No, in the liver, it's really a big deal. It's sort of borderline cancer. The biggest problem with adenomas is the risk of progression to hepatocellular carcinoma. So once you utter the word adenoma, you cannot relax. You have to either prove it or treat it or disprove it. So its proliferation of benign hepatocytes typically happens in women. The risk factors, there are some risk factors, such as oral contraceptives, diabetics, associated with glycogen storage disease, von Gerke, which is type 1, and then type 3, mature onset diabetes of the young, and even FAP. So there are multiple risk factors, and I think of it especially now with the fatty liver disease, and an insulin resistance risk factor is also possible. So there are molecular subtypes. Admittedly, this may not be a practical application because most of the histological correlation is not fantastic. But it tells you why we care. And we care because in 10 to 15%, which is the third bullet, there's a beta-catenin activated, and this group happens in men who use androgen, and it has high risk for malignant transformation. You also care because your first bullet, which is the most common one, inactivated hepatocyte nuclear factor 1, it's a germline, so it's actually a testable, inheritable mutation. It has lots of steatosis, and it has very low risk for progression. So unless you're an aficionado and belong to a place that they can make this distinction, the treatment usually on the aggressive side of removing it irrespective of what the molecular type. I will leave this in your syllabus. It just shows the different mutations that follow each one of the molecular subtypes, and the last line shows you and your pathologist what you can stain in order to make those molecular correlates. The most common type, the HNF1 mutation, is the steatotic type. Liver cells appear normal, isolated blood vessels, but look at the underlying thing. There's no accompanying bile ducts. Now, unlike all those previous comments that I mentioned for which the clinical relevance is not clear, this one is clear, because I'll show you how you make the distinction in imaging between that and your friend FNH, the relax and the don't relax. So if you look at imaging, non-contrast, isodense, hypodense, heterogeneous arterial enhancement, another example of a speckled enhancement, then on the arterial phase, it takes up. It reminds you of something? Yeah, hepatocellular carcinoma. That's why it's sometimes difficult to make the distinction between them. But look at the last two pictures, ENF. A hepatobiliary phase in a gadolinium-based contrast, there is no uptake. Okay? There's nothing. Look at how beautiful it is because of the issue of absence of bile ducts and an absence of a receptor on the hepatocytes that I'm not going to bother you with, but basically there's no uptake here. So if you line it up next to exactly FNH, look at the contrast. If you do an MRI with a gadolinium-based contrast, there is lesions with no hepatobiliary function. Guess which one is that? It's the adenoma. That's showing nothing. It's to your right. And then there are lesions with normal hepatobiliary function that will accumulate. Bingo. You make the distinction. Relax to the left, don't relax to the right. So if you don't relax to the right, what do? I think most of us think, and probably wrongly, that you advise them to lose weight, control diabetes, stop oral contraceptives, it's going to go away. I have to say, in my experience, they almost never go away. So you have to follow it up to actually make sure that it goes away, because you eventually have to remove it. So the groups that are really, really odd and should raise every alarm bell, a man, an increasing size, and increasing or stabilizing size off oral contraceptives. And if you know how to look at the histological correlates of beta-catenin inactivation, then these are really high risks that I tend to be aggressive up front, as opposed to waiting and seeing. Okay? So we're almost at the end. I would like to summarize. So the hepatocellular carcinoma, early arterial enhancing with delayed washout. Treatment, another talk for another day. The main differential in a cirrhotic is intrahepatic cholangiocarcinoma. There's a peripheral rim of enhancement in both arterial and venous phases. There is a capsular retraction and adjacent biliary ductal dilation. Again, talk for another day, treatment for another day. Hemangioma, the most common thing you're likely to see. It's hypodense, well-defined lesion, peripheral nodular enhancement, centripetal filling, homogeneous filling eventually. Most of it doesn't require any treatment. FNH, surprisingly common. It's your second most common lesion, basically normal hepatocytes, just disordered arrangements. It's an isotense mass, enhancing central scar, 50% of the cases. Most do not require intervention. Adenoma, well-defined, hypoattenuating with heterogeneous enhancement during late arterial phase, and no uptake of gadolinium-based contrasts. Stop oral contraceptives, androgens, control metabolic risk rates, but do not relax. Unless it goes away, resection in male or high risk, and transarterial embolization if there's bleeding or non-surgical candidates. This is my last slide. Thank you again, and let's do it.
Fantastic job, Hashem. Really well organized and well presented. So we'll ask Paul now to return and talk about hepatitis B and C. What is new for 2022?
Thank you so much. So we're going to talk a little bit about the basics, but I'm also going to try to include some of the more recent developments and observations in viral hepatitis B and C. So here, this was just presented at our liver meeting about a month ago, is the current cascade of care in hepatitis C. So as all of you know, you're going to learn, you can cure hepatitis C virtually all of the time. And in fact, it is probably one of the few diseases that we have the potential, doesn't mean we will, but to eliminate without a vaccination. We have that. There's only been one disease thus far that I know of that has ever been eliminated without a vaccine. That's river blindness or onchocerciasis. And actually, it was so interesting, those individuals who identified ivermectin actually won a Nobel Prize for that many years ago, just like some of the key leaders who played critical roles in discovery of hepatitis C last year won the Nobel Prize in medicine. So with that introduction here, right now in 2020, estimated right now that there are 1.8 million, this is in the center red, individuals who have hepatitis C. We've actually, since the direct-acting antiviral agent era has been entered, we've actually cured over 1 million individuals successfully. However, as you'll see, we have a growing epidemic. Still, there's a big gap. Over half the individuals are not yet diagnosed, and because of the pandemic, just 100,000 people treated in 2020, so we have to do better in that realm. Why is this happening? Because the epidemiology of hepatitis C has changed. So for years, we talked about this being the baby boomer generation. You went to Woodstock, you got hepatitis C. And again, it was injection drug use, intranasal cocaine use, blood transfusions. That has changed in the last decade. And now this is predominantly, the growth is in those who are ages 20 to 39. And again, all of you know about just the tragic opiate epidemic that has occurred, much of it in the Midwest. And we have a huge outbreak of this in California as well. And so it's younger people now getting hepatitis C. And so the good news is they have less advanced liver disease. The downside is we obviously need to get control of this. And treatment has evolved. We're going to just talk about what's new in 2022. What's new is that we have simplified regimens. And I like to say gastroenterologists have actually played a key role in curing many diseases. Not many subspecialties or specialties can say that. Helicobacter. When I was a medical student, our wards were filled with peptic ulcer disease patients. And I noticed we recently, when I was rounding, had a perforated ulcer come in on the service. It was standing room only for the surgeons because nobody had seen an ulcer that was oversewn. No one had seen this, and all the surgery residents were trying to get in and get an experience with this. And that's because of Helicobacter identification. So with hepatitis C, we have simplified regimens as well. And particularly, we have two pangenotypic regimens, and essentially, if you use these two, you don't actually even need to genotype the virus anymore. You need a few laboratory evaluations prior. You need to look for hepatitis B, HIV, do some drug-drug interactions, and then, of course, proceed with treatment. The key aspect of treatment in 2021 and 2022 is you need to stage the fibrosis. So Hashem just gave us a wonderful talk about who you needed to be careful and you really needed to be alert about. These are the individuals with cirrhosis. So we used to do liver biopsies. We no longer do these because we have multiple ways to non-invasively assess fibrosis. Most of us use elastography, which can be done here. This is an office-based fiber scan or transient elastography, but ultrasound can do this as well. There are serum biomarkers, some very easy, like the AST platelet ratio index or FIB4. Others are commercial markers that are also available. And of course, we have imaging. If you have a nodular liver, then you've identified the person has advanced fibrosis. But with hepatitis C, you absolutely need to know whether or not they have advanced liver disease, that is cirrhosis. Here are the first-line treatment options, and the bottom line is that when you are talking to your patients with viral hepatitis, no matter what you give them, if you use a recommended regimen, cure is expected. And again, these are all of them. We really use the two over here, glecaprevir or preventosvir, which is Mavyret, or sofosbuvir or velpatasvir, which is Epclusa, both very, very high SVR rates. They both are just outstanding treatment options and treat across all of the genotypes. What about all the special populations? So this is where I made my career, and as I like to say, this career condenses 22 years of my life, because this is essentially, we spent years trying to treat these advanced people. We used interferon therapy, some of you remember these, and now we give pills for just 12 weeks, 8 weeks, and we are done. So this is just really just shows you the advances that we've had, but all of these populations were so difficult to treat are now treated routinely in your office. There we go. One minor comment, there is a small risk of hepatitis B reactivation if you see the rare patient who has hepatitis B and hepatitis C co-infection. Now, you don't see these very often, it's just a couple of percent, but if you have somebody who has hepatitis B surface antigen positivity, you need to assess their hepatitis B to see if they need to be treated. That would take priority, and then you would treat the hepatitis C. If they don't meet treatment criteria and they're still surface antigen positive, then we typically just prophylax these individuals. Perhaps in the discussion we can get everybody else's opinion. I've just found it a little bit too hard to chase down the viral loads if you're monitoring during treatment. This is for surface antigen positive. What about core antibody positive, surface antigen negative, because that's part of the evaluation? There were a few reports of reactivation, but now the larger trials have shown that reactivation is very, very uncommon. If you're core antibody positive, and subsequent to that, we simply educate our patients that during treatment, if you get right upper quadrant pain, let us know. The risk is extremely low. What about those that are treated? You bring them back, and by the way, no laboratory monitoring during treatment. You just give them their prescriptions, and then you confirm SVR 12 weeks afterwards. What about these individuals whom you cure? So, without advanced liver disease, and again, this is the growing epidemic of younger people, you send them on their way, except if they still have ongoing risk behaviors. You need to counsel these individuals then that they need periodic testing. We typically tell these individuals, maybe not with us, but once a year they need to get an anti-HCV or HCV RNA PCR test done to make sure that they have not reinfected themselves. Cure does not prevent infection. You also have to make sure that the ALT truly normalizes. So some people, unfortunately, can celebrate their cure by gaining weight. Some people actually then may drink more heavily because now the hepatitis C is cured. If the ALT is not normal, you should be still following and evaluating for other liver diseases in those instances. You survey those with hepatitis C-related cirrhosis and liver cancer. The guidance has really varied over time. So I thought Hashem did a very good job of saying that with hepatitis C and F3 fibrosis, you need to be alert. Our guidance recently changed, and now it's F4 fibrosis after cure. And so these individuals need twice yearly ultrasounds with AFP levels. I will tell you, the F3 used to be part of this. It was recently removed. And what I would say here is it gets a little bit complicated. There is F3 and then there is F3. So there are some F3 where the platelet count is 250,000 and there's no signs of liver disease. I dismiss those. But if you had F3 and the platelet count's 150,000, then I continue to survey these individuals for hepatocellular carcinoma. That is one of the few nuances. And then if they have cirrhosis, they need a baseline endoscopy. We also now treat acute hepatitis C. So this was also a very interesting topic years ago. You would see somebody who had recently had, usually it's injection drug use, they had an ALT that was maybe 500 or 1,000. About a quarter of individuals actually develop signs and symptoms of hepatitis when they get acute hepatitis C, just about a quarter. So we used to say, let's see if they clear their virus, and if they don't, then you go on and you treat them. Now they're engaged in care. The treatment is so short. If you see this, if you document viremia, you should just move forward with treating these individuals. And the reason this recommendation was made was not only because of the high efficacy, but because modeling studies show that it actually is cost savings to treat hepatitis C that is acute. So if you see acute hepatitis C, they're engaged in care. You know, what we see in the office oftentimes are young individuals come in with their family. You know, they've moved back home and they have a structured environment. Now is the time to move forward with treating these individuals. This is an entire another many-hour topic, which is if you have liver cancer, which Dr. El-Serag just discussed, and hepatitis C, and whether or not you should treat the hepatitis C. The initial reports actually raised some concern that hepatitis C direct-acting antiviral agents could actually change or accelerate the biologic behavior of hepatocellular cancer, make it more aggressive, particularly if you lived in Barcelona, where most of these reports seem to come from. But larger, well-controlled studies, this was a multi-center study that was done in the US, showed that actually if you treat the hepatitis C in this context of treated hepatocellular cancer, then actually you have a survival benefit while treating the hepatitis C. So again, if you have both, the hepatitis C will take a secondary priority to the liver cancer, get the liver cancer treated first, but then you should not necessarily not treat the hepatitis C. Work with your transplant centers in these settings because transplant centers often use hepatitis C positive organs, but again, treating does not lead to a poor outcome. And again, we're all going to decentralize our approach to hepatitis C. It used to be everybody would travel to see Dr. Shetty to see hepatitis C in Baltimore or Dr. El-Serag. Now, family physicians, you see them, you get a point of care test. We're transitioning now to where we see them and we test and treat point of care, and this is how worldwide we're going to eliminate hepatitis C. Again, hopefully without a vaccine. There was a large vaccination trial reported recently that did not work, and I think that's many years away if it will work. Let's transition quickly to hepatitis B. So hepatitis B is also increasing in prevalence in the U.S., also tragically because of the opiate epidemic. And currently there was a nice consensus paper in the Red Journal that estimated maybe 1.5 million to 1.6 million persons now infected with hepatitis B. This is largely those that are immigrants. And again, you can see here that these are some of the various groups that are represented here. So Asia, Africa, Eastern Europe, and other areas. The serology markers for hepatitis B. So again, I've included them here just as a reminder, but surface antigen confirms infection. The surface antibody is immunity, and for acute hepatitis B, it's the IgM core antibody. What has changed now is that we have actually a quantitative hepatitis B surface antigen level that is available. And while not recommended yet by practice guidance documents, over the next few years, now that we are starting to see this, other strategies to cure hepatitis B, the level of surface antigen is going to make a difference. You can get this at Quest and LabCorp. Some labs do this. But what this does is this reflects the amount of hepatitis B that is in the hepatocytes, what we call the circular, covalently closed circular DNA, and cccDNA. And so you can have somebody on one of your antiviral therapies, tenofovir and entecavir, beautifully suppressed HBV DNA undetected, normal liver tests, the surface antigen quantitative level can still be very high because it's not in the bloodstream where you're measuring it, it's in the liver. And if it's low, that's actually a good news. But keep an eye on this because this is something that is going to evolve to a standard of care test. Not yet quite ready for routine practice. I bet if I ask, some people measure this, if I ask. So when do we treat hepatitis B and who do we observe? So here is the natural history of hepatitis B. So this was a very helpful table here that was created by the Europeans in their practice guidance from 2017. And they categorized hepatitis B into infection and hepatitis in various phases. So phase 1 is just infection. So these are the immune tolerant young people that we see. Teenagers, very high viral levels, E antigen positive, but normal ALT levels. And currently, we don't treat these individuals, although I suspect in 10 years that's going to be different. But right now, we don't. But then over time, the immune system evolves, and you develop a hepatitis with an elevated ALT level. And this is the immune system now that is trying to kill the infected hepatocytes. It drives the viral level down. But then again, you get a hepatitis, and because you have ongoing necroinflammatory activity, you have the progression for disease progression or fibrosis. So these are individuals that we treat with elevated ALT. This transitions to E antigen negative chronic infection. So what happens here is you clear the E antigen, and then the viral level becomes very low. The ALT level is normal. We observe these individuals. But these individuals over time can reactivate. And so you can actually develop a hepatitis, typically with a slightly lower HBV DNA level. But when the ALT level goes up, again, you need to initiate treatment. And again, if the surface antigen clears, which is the chance is very low, about 0.5% a year, then that's the best of all. I tell these individuals, go buy your lotto ticket. You're extraordinarily fortunate. And these individuals then have resolved hepatitis B. And this is the endpoint clearance of surface antigen that, of course, all therapies are trying to use as their primary endpoint. If you see someone, the first year I do a liver panel every 3 months or so just to get an idea of what the ALT is doing, and the DNA levels every 12 to 24 weeks depending on if it's a borderline for treatment or not, and you should be checking E antigen at least once initially. If you are going to treat, you need to monitor renal function, and we'll go over that shortly. The ASLD guidance. So who do we screen for hepatocellular carcinoma? So I show you here the ASLD guidance. So all cirrhosis patients, anyone with a family history of hepatocellular cancer, those who are Asian or African American men greater than the age of 40, Asian women greater than the age of 50, and anyone who is co-infected with hepatitis D. And typically this is an ultrasound and an AFP level every 6 months. If you ask all the hepatologists up here, there are going to be other groups included in the screening as well, but this is what the guidance says we have to do. If you have very active hepatitis B, for instance, and initiate treatment, I screen these individuals as well. Antiviral disease. So patients sometimes are resistant to starting, but one of the things you have to tell them is that hepatitis B therapy improves and halts disease progression. So this is with one of our very first medicines many years ago, lamivudine, and what they showed here was that in those with bridging fibrosis, that you prevented hepatic events. That is, that you prevented liver cancer, you prevented cirrhosis progression. So these therapies all are highly effective in this manner, and our first-line therapies now are excellent. Who are the candidates for hepatitis B therapy? I show you the latest guidance, including a US algorithm that was just published just a couple of months ago. They all depend on the viral level as well as the ALT. So the other thing when discussing treatment, if you have a high ALT and your patients are resistant to treating hepatitis B, I'm actually very direct with them, and I say hepatitis B is a carcinogen, and it is, just like Helicobacter is a carcinogen. WHO has classified it as a carcinogen. Do you want a high level of carcinogen in your bloodstream, or do you want an undetected level of carcinogen in your bloodstream? And again, we know based on some data from the REVEAL study published many years ago that there's a biologic gradient, and that's where the guidance here has evolved from. And so you can see here with high viral levels here, 20,000 international units, and an elevated ALT, that most of us would evolve and say these individuals need to be treated for hepatitis B. And again, the US and ASLD guidance are on the third and the fourth columns here. But once the ALT comes up, you need to be contemplating treatment for these individuals. Other caveats, the ASLD guidance is now more flexible. If you have a low fluctuating 1 to 2 times the upper limit of normal, if you can't explain it, you should treat these individuals. If you have cirrhosis and any viremia now, you just treat these individuals. And if you're decompensated, if they come with decompensation in addition to evaluating for transplant, doesn't matter if they have detectable HBV or not, you just treat these individuals as well. And again, there are some immune-tolerant individuals that are now contemplating treatment for. I will again tell you that as therapies improve, my belief is that we're going to be treating all of these individuals. Not yet, but it will be coming. So the preferred therapies are in the first column here. We typically use nucleoside or nucleotide analogs. Tenofovir disoproxil, that's Viriad. Tenofovir alafenamide is Vemlidy, and entecavir or Baraclude. And all of them are actually are highly effective and can be used relatively interchangeably for treatment of hepatitis B. Entecavir and tenofovir disoproxil or Viriad have generics, and so for some of these that are expensive, I'll just tell you, if you send them with a good RX coupon to Costco, you can get these for like $25 or $30 a month. So it's actually quite inexpensive. And and then rarely, if ever, we use immune modulation PEG interferon. On the syllabus, on the other slides I gave you also the dosings for renal dysfunction as well as for those with cirrhosis as well. When you initiate therapy, a liver panel every 12 weeks, not because the nucleotide or nucleoside analogs are ineffective. You actually want to make sure they're taking it. And that's the important aspect. Check an HBV DNA level for the very same reason. And again, if you're on tenofovir disoproxil, you need to check a creatinine clearance. There is a renal tubular off-target effect with this one as well. Adefovir was an older drug. I actually saw someone recently, to my astonishment, on that medicine. I didn't know anyone was still on it, but that also had a renal toxicity signal as well. So if you're on tenofovir disoproxil, you do need to be testing a serum creatinine periodically. Again, tenofovir alafenamide, one of the newer agents, has fewer off-target effects and is comparable in that sense to entecavir. So can you stop treatment? So this is the reason to use interferon, because interferon is a finite 1-year duration, getting patients to take this is sometimes a challenge. And I have written maybe 2 interferon prescriptions in the last 5 years of people who are willing to take it. Nucleotide analogs, if you're e-antigen positive, and these are younger individuals, the guidance says you treat until you clear e-antigen and produce e-antibody. And once you do that, you consolidate, given another year therapy, and the guidance says you can stop. I now continue these individuals as well because the relapse rates are actually still quite significant, and maybe during the discussion we can get other people's input as to how they approach this. But the guidance says consolidate for a year and then you can stop, and there's a chance they'll maintain what we call an immune control. For e-antigen negative, it's indefinite therapy or until 1 year after surface antigen clearance, which is a functional cure. This happens less than 1% chance per year. I reviewed the abstracts from our recent AASLD about stopping these treatments prematurely, and it's not ready for prime time, in my opinion. So I think we stay here for now. And if you're a cirrhosis patient, you need lifelong treatment. Don't forget about pregnancy because, again, we want to prevent hepatitis B, and this is your chance to make sure the next generation doesn't get it. The approved therapies are lamivudine, talbivudine, and tenofovir, but practically speaking, we all use tenofovir disoproxil because that's where the most data is, and this was a very nice study from Calvin Pan from New York who looked at vertical transmission in China. On the left is you can see here the tenofovir treated group, which is, and then on the right you have the control group. Intention to treat is red, and blue was per protocol. And you can see in those who actually completed all the treatment, there were no transmissions. You also need Hep B immune globulin, preferably within an hour of birth as well, because that's when the highest transmission risk occurs, and breastfeeding is not contraindicated. Vaccines, so just this past week, the ACIP recommended universal hepatitis B vaccination for all adults aged 19 to 59 years. Hepatitis B also has now 2 new vaccines, and in fact, one of them, the press release just came out last night. So the one that was approved a few years ago was Heplisop. This is a surface antigen vaccine that has this CpG adjuvant, which boosts the immune response, and it's 2 injections, 0 and 1 month apart. And why that's important is because I think it's a little easier to bring someone in as opposed to the traditional hepatitis B 0, 1, and 6 months. So I think people fall off after the 6 months. And so we tend to use this one because it works a bit better in difficult to treat patients. However, this just yesterday, the FDA panel approved this recombinant trivalent hepatitis B vaccine, which is this pre-Hevbrio, which contains actually not just the S antigen, and this may go under the category of too much information, but there are actually 3 different surface antigens. There's a small, medium, and large, and so this particular vaccine uses all 3 of the antigens to generate a better immune response. And don't forget the other ones. They still are effective, but this pre-Hevbrio also, just like the Heplisop, was actually more effective than, I think they compared it to the Merck, the Energix vaccine. So that was something that should be coming out in addition to our other vaccines. So there is a proliferation of immunosuppressant cytotoxic therapies. We use them for inflammatory bowel disease. The rheumatologists use them. The oncologists use them. And remember, there are a tremendous number of people out there who are core antibody positive as well as surface antigen less so. But hepatitis B reactivation remains an ongoing issue, and I think if we check with all the transplant hepatologists up here, we all see hepatitis B acute liver failure in very difficult circumstances because people don't look for the hepatitis B. So if you see somebody and they are surface antigen positive, you need to tell them if you get on any kind of immunosuppressive agent, you need to be followed by somebody who has experience in this and potentially receive prophylaxis. And my own practice here is that for surface antigen positive, there are very few you don't prophylax. There are some groups, but not too many, just low-dose prednisone and a few that are short courses. Everybody else needs prophylaxis. Core antibody positive, surface antigen negative is different. There you can monitor with on-demand therapy, or you can put these individuals on prophylaxis. What I would say is that over time, I'm evolving more to prophylaxis rather than monitoring, simply because if you monitor, you truly have to monitor. And we've had a few near misses. Somebody goes on something and then their chemotherapy is intensified, and then they don't tell you because they're upset because their disease changed, and you only find out later that they are on now a much more potent drug such as rituximab, and so you have to follow these individuals closely if you monitor. There is nothing wrong with monitoring, you just have to make sure you have a good mechanism that is in place for these individuals. And any of our first-line therapies work very, very well. Lots of new targets for hepatitis B out there. Right there, I would tell you this is not different than Dr. Shetty's NAFLD slide, right? There's tons of these out there, lots of different mechanisms, but it's still very early for hepatitis B right now. Lots of options out there. This will be something, though, it's going to take a few years to sort this out. So in summary, when to start therapy: elevated HBV DNA with an elevated ALT, or significant disease on elastography or rarely liver biopsy. And the thresholds for treating are starting to fall, and that's going to continue as we get more effective therapies. When do you stop or alter treatment? So e-antigen positive, it's seroconversion and undetectable HBV DNA, although some, including myself, continue these individuals to surface antigen clearance. E-antigen negative, it's long-term, it's a surface antigen negative. Inadequate virologic response, then you would switch therapies, but again, the therapies are outstanding. If the viral level is not going down, check rigorously for compliance. The novel agents are coming, but they're not yet here. Hopefully, over the next several years, though, we'll have additional options for these individuals, because this is obviously a disease where we still need major advances. I will stop here, and again, thank you so much.
We're going to have some case presentations now. Dr. Murley will direct that. Just to remind you, if you have questions, come to the microphones here, and Dr. Murley and I will try to integrate those into the cases.
Thank you. Thank you, Dr. Varadarajulu and Dr. Haas, for having me here. And thanks a lot to all our speakers for the fantastic presentations and for sharing your knowledge with us. So we have a few cases, and either at the end of each case or at any time, if you have any questions, please ask us. I think it's important that we are able to answer those questions. These are my disclosures. There may be mention of some off-label or investigational products. So our case one is a 55-year-old male with chronic hepatitis C. He was asymptomatic, history of intravenous drug use, currently no alcohol misuse or drug use. On examination was unremarkable. His CBC, BMP, INR are all within normal limits. Platelets were 224. Hepatic panel showed ALT of 87 and AST of 65. Alpha-fetoprotein was normal. Hepatitis B, surface antigen and core antibody, non-reactive. HIV is non-reactive. Hepatitis C viral load is 1.7 million. Fibroscan was performed, which showed F3 fibrosis and no steatosis. So we did a liver ultrasound, showed a 2.2 centimeter hypoechoic focal hepatic lesion. This was followed with an MRI, which showed a 2.4 centimeter lesion with arterial hyperenhancement and washout to hypointensity on the venous face, Leirat's 5. No imaging evidence of ascites or varices, mild splenomegaly. So the discussion, the first question, Dr. El-Serag beautifully explained to us what we need to do next. This is a Leirat's 5 lesion. This patient has HCC, so we do not need to biopsy this lesion. So we'll move on to the second and the third questions in the discussion. So this patient has hepatitis C. This patient has HCC. He has a single liver lesion, no clear evidence of portal hypertension, and he also has hepatitis C. So how would you time treating his HCC? How would you treat his HCC? And what about the timing regarding the treatment of his hepatitis C?
Well, does this work spontaneously, or do I have to scream? No. Okay, I'll scream then.
Can you turn on his microphone, please?
You know, given that I'm not a transplant hepatologist, so I can relate to most of you, if you have something like this, I would refer it to a place that they have all the subspecialties under one roof, where they have a tumor board, where they have a surgeon, a hepatologist, and a radiologist. Because otherwise, if you send it to any of these disciplines, somehow magically they'll end up getting that treatment only. So, this is a small tumor, which is, you should celebrate that you caught it. In the setting of someone who's compensated, this person could be eligible for many potentially curative treatments, so I would hand it to you.
Go, Kirti. Now, go. Yeah, go ahead.
Thank you, Dr. El-Serag. As Dr. El-Serag mentioned, most transplant centers have a multidisciplinary approach to this. At our center, and I'm sure at many others, we have a weekly liver tumor board where we discuss these cases, and it is truly multidisciplinary. So I would agree with that. I think I missed the platelet count.
224.
244. And did we have any splenomegaly?
Very mild splenomegaly.
Oh, okay.
But no.
So those are the two important questions that you need to ask in trying to decide whether a patient is an appropriate candidate for for hepatic resection versus liver transplant. This patient falls within what we call the Milan criteria, which prioritizes them for liver transplant, but that is probably something that can be kept in reserve. So this is a patient who probably should be evaluated by a liver surgeon for hepatic resection. What do you think, Paul?
Yeah, I agree. I agree completely. And I'd just like to say, when Hashem put up the screen F3 and keep your guard up, this is a perfect example because it was F3. And but actually there was some evidence of it more advanced liver disease, probably in F3.5, right? Right?
True, because I'll get to you over here in the case. Thank you for all the comments. That's exactly what we did for this patient. So we'll move on to this case. If you look at this case, he had no clear evidence of portal hypertension. So we performed surgical resection of his HCC. In fact, on the biopsy, he had F2 fibrosis on his liver biopsy. And this is like the fourth patient in the last 3 years that without any cirrhosis has actually had HCC, all in the setting of hepatitis C. So he had surgical resection of HCC. His post-operative course was uneventful. His MRI 3 months after resection showed no recurrence, and then we initiated the DAAs, and he achieved SVR. So he's currently doing well at 3 years follow-up without any recurrence. So the other question is, you spoke about hepatitis C and HCC. So normally we treat the HCC, we wait, and then we treat the hepatitis C. Is that the right approach, or is there any special scenario where you might consider treating before you consider treating the HCC?
No, the order doesn't really matter so much. Okay. But again, the prioritization is the hepatocellular cancer. If you're going to go to transplant, actually, there was a recent paper by a large U.S. consortium of liver transplant centers that seemed to indicate that the lowest recurrence rates were if you treated these individuals right after transplant. That is, within 1 to 3 months of transplant, the lowest recurrence rates were reported. So in this particular case, we would have done exactly how we would have done the same, or approached this patient in the same way you did.
Okay.
So,
yes, go ahead.
Just a couple of comments about this. It really highlights why you need a good CAT scan before you start treatment of anyone with hepatitis C, because stuff like this could be present at baseline, and you treat them, and oops, next thing you find a cancer. Well, you should have found it early on. The second is about the treatment. I mean, it's an issue of priorities, and the first priority has to be the cancer. And given that there's this Barcelona suspicion that you may worsen things with treatment, treat the cancer, make sure it's kind of gone, then treat the hepatitis C.
The other important question now to the panelists here is, there were some studies that came out of Europe regarding lower SVR rates in the setting of active cancer. So do you believe in that, or what is your approach?
Yeah, and one from Northwestern University also had the same. So it may actually be there, although the more recent papers suggest the lower SVR rates are only in those with active cancer. And just so for everybody, what everybody is just thinking is that the DAAs don't get into the hepatocellular cancer hepatocytes as well, and you have slightly lower SVR rates. What I would say is it's a modest decrement, but I still think treating the hepatoma first and then subsequently treating is what we would, as Hashem said, I mean, get rid of the life-threatening disease first.
Yeah. Thank you. Thank you so much. And if anyone has any questions regarding hepatitis C or HCC. Okay,
so after you cured this person, I assume this person would have surveillance for life,
yes,
because you left a
yes,
diseased liver behind despite treating HCV.
Yeah, so he is going to be getting surveillance. We are not going to be sending him out of the liver clinics. So second case, So the hepatitis B, so this is a 45-year-old male. He was referred for the evaluation and management of chronic hepatitis B. He's originally from Northern Africa. He has no history of jaundice as per his recollection, no other past medical history, currently no alcohol misuse or substance abuse. His physical examination was unremarkable. And lab says WBC count was 3.2, his hemoglobin was 14.2, platelet count is 144, his absolute neutrophil count was 1154. His BMP was normal. On hepatic panel, his bilirubin is 1.2, AST is 184, and ALT is 226. So his workup locally, surface antigen was reactive. Hepatitis B core antibody was reactive. His hepatitis B DNA was 3.2 million. E antigen was positive. Hep C antibody was negative, and HIV was negative. And when he presented to clinic, he also got his hepatitis delta. And his hepatitis delta viral load was 4.2 million international units per ml. His ultrasound with the liver Doppler showed no evidence of cirrhosis or portal hypertension, no focal liver lesions. Fibroscan revealed F3 fibrosis and no steatosis. His alpha fetoprotein was normal. So this is, you have a lot of treatment in the pipeline for hepatitis B and fatty liver disease, but this is a patient who has both hepatitis B and hepatitis delta. So how would we approach managing this patient? Would you first treat the hepatitis B, or would you try to treat both at the same time?
So, I would just like to say, great that they checked the hepatitis delta. So you start thinking about delta whenever you see someone with hepatitis B and the ALT level is very high. I mean, that is just automatically should trigger that this person is potentially co-infected with these individuals. So there are no yet approved therapies for hepatitis delta yet. So the one therapy that is just very tepidly recommended, and I mean tepid, is interferon. And it doesn't really work, and you have to give it for a very long duration. So in this individual, the immediate priority is he's E antigen positive. You should immediately put him on a nucleotide analog, because that's probably going to reduce the necroinflammatory activity substantially, while at the same time either calling your center for a clinical trial of choice or somebody's center for a clinical center looking for access for a hepatitis D trial. And there are multiple options that are out there now that are being explored. There's medicine bulevirtide, which has orphan status in the U.S. and has been conditionally approved in Europe for hepatitis D. There are a couple of lonafarnib and peginterferon lambda that are being studied here, as well as another study with an siRNA therapy for hepatitis delta. I would be looking for clinical trial of choice. But what you can control in your office is the hepatitis B, so you should treat that immediately. But this individual who's young, and as he will probably go over, the natural history of hepatitis delta is such that you have very rapid progression of disease in this particular viral infection. It's the most severe, and people can progress to cirrhosis in 10 years or less. He's young, so you have to be much more proactive.
Thank you.
I think on the more basic level, given this up-and-coming delta treatments, testing for delta as a baseline testing for the Hep B, which most of us never did, including myself, is coming up. So now I do them because I think eventually we'll use some of that, and that's probably a good point to remember.
Yes, absolutely. When you teach the fellows and the residents, I think there are 3 infections, co-infections that they have to rule out, two actually, hepatitis C, HIV, and Delta 3, whenever they diagnose a new patient with Hep B.
Thank you for the great discussion. So this is what we did to our patient. We briefly spoke about interferon initially. We started him on entecavir because of his everything Dr. Polko mentioned. Actually, at 6 months, his viral load came down to less than 20 international unit per ml, but his liver enzymes never improved. His ALT was 220, his AST was 142. His delta viral load had actually increased to 5.1 million international unit per ml. This is when we did a liver biopsy, showed significant inflammation, moderate portal inflammation, mild lobular inflammation, and bridging fibrosis. And we started him on PEG interferon alpha, which is probably the only one that we have right now. But like Dr. Polko mentioned, efficacy is very moderate, about 20%. We had to decrease his dose. So we had clinical trials on, and I'll show this next slide here. This is the medications that Dr. Ko mentioned. We have bulevirtide, for which we are trying to get approval for this patient, and it's interferon lambda. And then we have the prenylation inhibitor, or lonafarnib, but he had a neutrophil count which excluded him from all the clinical trials. So that was the problem with him. His absolute neutrophil count was 1100. We repeated it, hoping that magically it will be better, but it was not. It was 800, so we couldn't put him on any of the clinical trials that we had in our center. We spoke to NIH, and they are waiting on interferon lambda because they think they can use that even in patients with low neutrophil. But so for now, we have him on the interferon. At 16 weeks of therapy, his viral load is about 1.9, his ALT is 121, and AST is 99. But definitely a long road ahead of him. Hopefully, we can get either bulevirtide or interferon lambda for him. So the last case, third case, is a 38-year-old female referred for elevated liver enzymes. 2017, her liver enzymes were completely normal. In 2019, Jan, her AST was 78, ALT was 117. So ALT is about 3 to 4 times the upper limit of normal. 2 months later, her AST was 102 and ALT was 188, so almost 5 to 6 times the upper limit of normal. Alkaline phosphatase barely elevated at 122. So pattern recognition, like Dr. Polko spoke before, this is clearly hepatocellular pattern. Her bilirubin is 1.4. History and physical, she has class 3 obesity. Her BMI is 42. She also had central obesity. She has a history of dyslipidemia. She is on pravastatin for the last 4 years. Family history of metabolic syndrome, hypothyroidism, Sjogren's syndrome. Her current medications include OCPs as well as pravastatin, no other prescription medications, and no supplements. Her examination was unremarkable. So we did a liver disease workup, CBC, BMP, INR, and iron panel were all normal. Viral hepatitis panel was negative. Alpha-1 antitrypsin level and ceruloplasmin was also normal. Her autoimmune panel showed an ANA of 1:640. Smooth muscle antibody, even the LKM was negative. Antimitochondrial antibody was negative. Serum IgG was 1752. And the ultrasound with liver with Doppler was unremarkable. So in this patient, she is young, 38. She does have features of metabolic syndrome, but her liver enzymes are 5 times the upper limit of normal, and she has positive autoimmune markers. So we would not be able to biopsy all patients with fatty liver disease, but there should be a group of patients that we should consider biopsy. So Dr. Shetty spoke about fatty liver disease. So in this patient, how would you approach this patient? And do you think, what are the patients that we should target for a liver biopsy?
Right. So as Dr. Ko mentioned, there are so many non-invasive markers of fibrosis now that we don't use liver biopsy as much as we used to. But this patient probably fits the profile of somebody who should be biopsied because non-alcoholic fatty liver disease is really a diagnosis of exclusion, and you absolutely do not want to miss something treatable like autoimmune hepatitis. She has a history of other autoimmune disorders as well. So I would think the next step is probably a liver biopsy.
Thank you. So so this patient got a liver biopsy, and she had portal lymphoplasmacytic inflammation, interface hepatitis, mild portal fibrosis, and interestingly, she had minimal steatosis of less than 5% despite a BMI of 42 and dyslipidemia. So she has a diagnosis of autoimmune hepatitis. Okay, perfect. So thank you for that remark. And this is what the AASLD currently says, because we all see patients with fatty liver disease, and sometimes when they have class 3 obesity, they may not even be referred to us. They may be assumed to have fatty liver disease. But it's important to, when you're evaluating a patient with suspected fatty liver disease, it is essential to exclude competing etiologies for steatosis as well as coexisting common chronic liver disease. So high serum titers of autoantibodies with features of other autoimmune liver disease should prompt a workup for autoimmune liver disease. So we spoke about viral hepatitis, fatty liver disease, and so we'll finish this by touching base on autoimmune hepatitis. So this is a patient, she has metabolic syndrome, class 3 obesity. So anyone in the panel, is budesonide a reasonable alternative to prednisone to treat her?
I would think so, yes. I mean, there is data out there on budesonide, and the patients you want to avoid budesonide and go towards prednisone are the ones with more advanced fibrosis, cirrhosis, but yes, that would certainly be a good alternative.
Thank you. So we did start on budesonide, and this is what the AASLD says, just like what Dr. Shetty said. It says for children and adults who present with autoimmune hepatitis who do not have cirrhosis, the AASLD suggests using budesonide and azathioprine or prednisone and azathioprine as a first-line treatment. So moving forward to this patient, we put her on budesonide. She started on 9 milligrams. We also, even after 2 weeks, we started on azathioprine, 100 milligrams, and subsequently increased it to 150. She had no significant improvement in her liver enzymes. So eventually, we had to discontinue the budesonide, and we put her on prednisone, 60 milligrams, and we continued the azathioprine. liver enzymes were normalized within 4 weeks. However, when the prednisone was tapered down to 25, liver enzymes flare up. I think this is when we treat patients with autoimmune hepatitis, this doesn't happen often, but when it happens, it can be really difficult and challenging. So we did get the azathioprine level 6 Tg was 280, which is within normal range. So clearly she has failed azathioprine. So in this patient, how would you approach managing this patient, or what are the second line treatments that you would use?
Sure. So in this particular patient, the prednisone works, so that's good, because part of whether or not you have the right diagnosis is whether you normalize your liver tests on prednisone. So it was reassuring they did that. Azathioprine is not a particularly potent antimetabolite, and so in this particular case, for a variety of reasons, I would transition over to mycophenolate. And I would be pushing the dose up to as high as 1.5 grams twice a day as required, titrating. And again, this is a steroid-sparing agent, and I would hope that this would work. There are other agents as well, but they have other toxicities that you'd like to avoid. And as all of you know, if any of you use mycophenolate, it causes a little bit of anorexia as well. So, I mean, that's that's something you have to watch for. But that would be my first choice in this one.
Thank you. Thank you. So this is the study based on which the guidelines were made. So the efficacy and safety of mycophenolate mofetil and tacrolimus as second-line therapy for patients. And there are several other studies too. And the interesting thing in all these studies that I noticed was, if you look at the median of like 62 months in this study, the biochemical response was pretty good in patients who were intolerant to azathioprine, but in patients who did not respond to azathioprine, it was about 34% with mycophenolate in the study and 56% in patients with tacrolimus. So I think that's something that's important to note. So in this patient, we did the same thing. We made probably one thing we could have done differently was MMF. We usually do at 1 gram BID, maybe 1.5 gram BID could also be tried. But we increased the prednisone, we discontinued the azathioprine, we initiated the MMF. Liver enzymes flared again when prednisone was tapered down. So eventually we started on tacrolimus with a goal trough level of 8 to 10. And Dr. Polko mentioned it has a lot of side effects. We have to watch her creatinine and her kidney function, screening for skin cancers. And then eventually we were able to at least taper her prednisone down to 10 milligram, and she currently has normal liver enzymes, but the trough level has been quite high at 7 to 10 nanogram per ml. So this is one of the tough cases of autoimmune hepatitis. This ends our case discussion, and if any questions, yes.
Would you comment on, I sit on the tumor board, and when we are constantly evaluating hepatocellular carcinoma, we've got the classic and MRI or CT enhanced, everyone gets an alpha fetal protein. Where does that fit into your algorithm? Because in my mind, the alpha fetal protein is useless because it's accurate in less than 40% of our patients. And is there more an advanced biomarker that can be used? Because a lot of our physicians are using that, and if it's negative, they're saying they don't have hepatocellular carcinoma.
So good comment, and it's about the role of alpha-fetoprotein. And currently there are two roles for alpha-fetoprotein. One is a screening/early diagnosis, and one is prognosis. And I will let the transplant people talk about how they use it for prognosis. In my mind, it's a good positive predictive test if it is high and or increasing. So if you have it plus the classic features, it makes you feel good. If it's solid normal, I mean, it may make you feel yes or no, but in the presence of classic imaging findings, I would say you go with the imaging, definitely, because it is known that I think a third or so are non-alpha-fetoprotein producing, and so you may actually be stumbling on one of those. As far as other markers, the next marker or biomarker set that is being used is the triple biomarker, which is alpha-fetoprotein, L3, and DCP. If you're going to use them, you're going to use them part of this GALAD score, which adds age and something else to it. It improves it. It is marginally increases your sensitivity. In other words, you'll be picking up a little bit more tumors, but you'll be picking up a lot more false positive, so you'll be spinning your wheels on a lot of patients who don't have it. So unfortunately, at this point in time, we do not have a good marker. I think it's fair to say that. I'm not in favor of ditching the biomarkers completely, because maybe you do screening and surveillance religiously with ultrasounds and or CAT scans. Most people in the community do nothing. So if you tell them don't do alpha-fetoprotein or anything, then you're really asking for nothingness. It doesn't help the cause. But if someone does imaging, I'm okay with people dropping biomarkers for now. Personally, I do alpha-fetoprotein plus imaging and use the two together.
We have a question over here on the left.
Yeah, on NAFL, liraglutide versus pitaglitazone. A lot of us have been dropping pitaglitazone as the treatment, particularly those that don't qualify for research studies.
I'm sorry, I didn't.
I didn't catch the
So, yeah.
last part. So you're dropping one.
Semaglutide, is that what he said?
Many of us are not using
Pioglitazone.
Pioglitazone,
Yeah.
because you're not eligible for
in
clinical.
patients that don't qualify for research studies. We've been using liraglutide.
So what do you think of liraglutide versus
So, and then
pioglitazone?
GLP-1,
Yeah.
GLP-1.
GLP-1. So your question was about the routine use of semaglutide in non-alcoholic fatty liver disease?
Yes.
No, the question was,
GLP-1, okay.
the question was, they're dropping pioglitazone in a lot of these fatty liver disease patients because they're not eligible for clinical trials.
I see.
So-
I'm sorry, I didn't understand the
Pioglitazone,
question.
so what is the role of pioglitazone, and they're having to drop the pioglitazone in order to get some patients on
In order
clinical
to
trials.
Get into the clinical trials, right. So pioglitazone has been suggested by the ASLD as an agent to treat NAFL based on the PIVN studies I said, but it does have the side effect of gaining weight, and it isn't allowed in most clinical trials. But other agents such as the GLP-1 agonists are very effective and can be used, especially in those patients who have diabetes. Does that answer your question?
I was asking about the use of liraglutide in patients that do not.
Liraglutide.
Yeah, the GLP-1.
GLP-1.
In
Okay,
patients
so
that don't
liraglutide
qualify for research studies.
Yeah.
So liraglutide has been studied in a clinical trial and has been shown to be effective, but the data is awaited, as with most agents.
So I'm going to be controversial here. I'm actually a big fan of semaglutide in my diabetics, obese, and now they have Wegovy with the high dose that make them lose weight. There is a trial. It's not FDA approved. They're still doing trials for the endpoints of NASH, but there is one large trial that shows some reversal of fibrosis with semaglutide. So right now I'm using it with the excuse that you're diabetic, you're obese, and you have NAFLD. Why not work with the endocrinologist and do it?
I agree completely. And the other thing is it has an indication for obesity.
Yeah.
So many of your NAFLD patients, as Hashem was saying, are going to be diabetic and obese. And so that you can actually have them start this. And, you know, the downside is it does cause, if you have gastroparesis, it's not a well-tolerated drug. Oh, well, we should, okay, yeah. Dr. Camilleri, why don't you just educate us?
I wasn't going to talk about gastroparesis, but the point is that there is a network meta-analysis that has just been published by eClinical Medicine that shows semaglutide subcutaneous is the best. Semaglutide, slightly lower dose, 1.8 milligrams per day or less, is slightly reduced efficacy for weight loss and for effects on AST, ALT. And even the oral semaglutide is almost equivalent to liraglutide subcutaneous. So there are wonderful opportunities for us all to come together, and very few patients will actually get long-term gastroparesis symptoms. Absolutely. And it's been shown that there's tachyphylaxis by a study that was done at Mayo Clinic, tachyphylaxis in the effects of the GLP-1 agonist. So the fact of the matter is we're all coming together. GLP-1 agonists can really help with the patients with the non-alcoholic fatty liver disease. And I'm not a hepatologist.
No.
But
Okay, right. I think with that, we'll wrap it up. We've gone over just a little bit.